We look at frontal sinus fractures. We've covered the NOE fractures, what they look like. To look at frontal sinus fractures, if it's a minimally displaced anterior table fracture, whether in isolation or in conjunction with an NOE fracture, you don't really have to go chasing after it unless it's causing a large cosmetic deformity, or if you already have a laceration in the area that's going to give you easy access, you don't really have to go chase at it. So let's say it's a type 1 that's displaced enough where you want to operate, and a minimally displaced frontal sinus fracture. You could leave the frontal sinus fracture alone unless it's causing a clear cosmetic deformity, but then it'd probably be more displaced and warrant being addressed. The next thing when looking at frontal sinus fractures is looking at the nasal frontal outflow tract. So you want to see if it's involved, if there's a lot of mucus or blood clogging up the sinus and not easily drainable. That outflow tract, you want it to be patent so that fluid can keep flowing out and you don't develop a mucocele long-term postoperatively. So that's what we think about when we think about looking at the nasofrontal outflow tract. Is it involved? Is it disrupted? If so, you may want to do a joint case with ENT where they run an endoscope up there. Or if you're going to flip a coronal for a more involved frontal sinus fracture, like a posterior table fracture, that's going to be something you consider. So when we're talking about a posterior table fracture,